my name is Peter Sun. I'm a pediatric neurosurgeon at UCSF, Benioff Children's Hospital. Thank you, Dr. Metz, for inviting me. Thank you for logging in. My talk today is on the pediatric cranial cervical junction. Obviously, we're not in an interactive environment, but this is my email. Please email me for any questions or cases. That may come up. I have no disclosures. Just to start off with some anatomy, in the pediatric cervical spine, the fulcrum of the cervical spine, due to the relatively large head of the child, is at the cervical cranial junction at C1-2. This is, of course, in distinction with the adult cervical spine, where the fulcrum is in a subaxial spine. And due to the developmental complexity here, not only is the forces concentrated at the cranial cervical junction in children, but also due to the embryology, there could be a variety of pathology at the cranial cervical junction. In terms of the biomechanics, we know that the vast majority of the rotation between the cervical spine is at C1-2, whereby the dens serves as a axis of rotation. We look at the anatomical relationships between the occiput and C1. There's really is very little rotation in this cup-like orientation of the joint, but there is some flexion extension, and then there's also a little bit of lateral bending. The vast majority of the movement across this complex is rotation at C1-2. And this really works as one unit between the occiput and C2, or the cranial cervical junction, whereby C1 really is the washer. The major ligamentous stability and the major muscular stability that is conferred across the cranial cervical junction really are structures that go from the occiput to the C2 in the back, and the occiput, the clivus, to the back of C1 in the front. While the segmental structures themselves, such as the apical membrane and the joint capsules, do confer some stability along with the posterior occipital atlantal membranes and the atlantoaxial membranes. It's really the big muscles that span the back and the tectoral ligament that goes from the occiput to C2 that confers major stability. Of course, the dens itself is held against the anterior ring of C1 with the transverse ligament as a major translational stability of this joint. And keeping this in mind, we can see later on, in terms of the ligament, the structures and disruptions and the measurements that we take at this area, can incorporate from occiput to C2, and not just limited within the segmental relationships between O, C1 and C2. So in terms of the classification of cranial cervical abnormalities, we can have, of course, acquired trauma or neoplastic, which is rare, but occasionally it can happen. We can have a host of genetic or metabolic disorders, and we can have congenital deformities, either of the occipital bone with basilar invagination, of the atlas with aplasia or occipital assimilation. In addition, we can also have Chiari malformation, which is neurological, with descent of the cerebellar tonsils into the cervical spine, which also carries associated bony anomalies that we will touch on. So the indications for treatment is, of course, neurological compression and instability. Along with the spectrum, also we have to look at the anterior pathology. The anterior compression also figures largely into our treatment paradigm. In terms of the neurological signs and symptoms. Obviously, there's a host of these because of the brainstem, upper cervical spinal cord, and cranial nerves. But also, I just want to highlight often that children can present with just a head tilt due to either brainstem compression or subtle cranial nerve difficulties that they have a little bit of a head tilt, and that can be the harbinger of a major cranial cervical abnormality. So on MRI, we're looking for the compression of this neurological structures, cord signal change, and the development of a new syrinx can represent subtle compression and alteration of CSF dynamics. So in terms of the bony criteria for clinical instability across the cranial cervical junction, there are a variety of measurements. I think because of the diagnostic uncertainty, oftentimes these patients are in polytrauma. Of course, they're not following commands. All these relationships have been developed, and obviously, on occasion, we would have a very obvious case like this where there is overt cranial cervical instability or distraction in a pretty much a lethal injury. Just going over some of these criteria, of course, we have the alento-dental interval, which we can accept up to 6 millimeters. And we are mindful that if there is greater than 10 millimeters of disruption of the alento-dental interval, the relationship with the occiput can also be disrupted, and that the tectorial membrane can be lifted up, and we have occipital cervical instability and not just limited to C1-2. Here we can see that there is major atlantoaxial instability, and this tectorial membrane is stretched off of the clivus, and then the posterior occiput is lifted up, in addition with this severe cord compression from the dens. In this case, the patient had a transoral decompression and an occipital cervical fusion, and not just a C1-2 fusion due to the laxity, the potential laxity of the tectorial membrane, which involves the occiput. So, talking about the dens-bayesian interval is looking at the relationship between the clivus and the tip of the dens. It's 10 to 12.5 millimeter is a upper limit of normal. Of course, in children, when we have incomplete ossification of the tip of the dens, this can be a problematic measurement where we can't see it, basically. And in terms of its dynamic stretching, should have very little change in flexion extension, less than 2 millimeters to 1 millimeter in adults. Here is a measurement device by looking at the Bayesian axial interval, or BAI, whereby we're looking at the relationship between the clivus to the back of the dens. If it's stretched forward, then of course the tectorial membrane could be involved, and we have instability in it. It's an anterior measurement. It's not a posterior measurement. We tolerate up to 12 millimeters anteriorly, but there's no posterior translational measurement, and we have no flexion extension data on this radiographic criteria of cranial cervical instability. Now we can look at the joint itself between the occiput and C1, and this measurement is upper limit of normal is felt to be between 3 and 5 millimeters. Obviously, if this is lifted up, as we talked about, it's the or if this joint is separated, is not just the joint capsule that had been keeping this firmly intact. It's the tectorial membrane in the front and the musculature in the back. So this is a direct measurement, best seen on CT data. There's a couple of ratios. One is Powers ratio, whereby if the cranium kind of moves forward relative to C1, then that's considered unstable. And the X line also is the cranium is moved forward relative to this line between the clivus and the back of C2, then it's felt to be unstable as the cranium is shifted forward. We also looked at some relationships, but not just between the occiput and C1 or C2, but rather a relationship that we can easily measure, measuring the C1-2 separation relative to C2-3. As you can see, this is a major distraction injury. It is separated at the synchondrosis, and we have a massive occipital cervical dislocation. But you can see that the C1 is super separated from C2 relative to the preserved C2-3 relationship. So this gave us the idea of looking at this ratio to determine whether we have cranial cervical instability. And when we look at the MRI abnormalities of the cranial cervical junction in trauma, the vast majority is in the cranial cervical junction and not in the subaxial spine, kind of illustrating our first slide, whereby we have a very large cranium, and as it rocks on the cervical spine, this is where the fulcrum of the energy is transmitted mostly. In the cranial cervical spine junction, there is the variety of injuries. We can have a little epidural hematoma along the clivus. We can have a separation between C1-2. We can have major muscle contusions in the back, as illustrated by this case. We can have an apical membrane abnormality, such as in this patient where the apical membrane is torn and we have some fluid, bloody fluid in the synovial joint. Here, one capsule is separated, the other capsule is intact. We can see this capsule on the right side is, of the patient is distracted. On the other side, it is still intact. This is another capsular separation, and then we move on to whenever there is bilateral capsular separation. When we looked at these injuries, there's always tectoral membrane injury. Either it's lifted off of the clivus with a massive anterior hematoma, or it actually becomes torn itself, such as in this case where the tectoral membrane is torn, and of course there's massive distraction cord injury and a big hematoma in the musculature. So there is a spectrum of injury across the cranial cervical junction. We can have isolated muscular abnormalities. We can have ligamentous abnormalities that involve the apical ligament. We can have one joint that's disrupted. But whenever we get to where bilateral joints are disrupted, or we have spinal cord injury, or we have complete AO dislocation, the tectoral membrane is always involved. And we consider whenever the tectoral membrane is involved that we're moving from the stable to the unstable spectrum. So all tectoral injuries also had AO joint disruptions, and all patients required fusion had tectoral membrane injury in our study. Furthermore, when there's tectoral membrane injury and they were not operated on and treated conservatively, the 2 or 3 patients that had this all had some degree of basilar impression. They didn't go on to have overt instability and this settled down, but we can see that there is some a permanent change in the bony relationship whenever we have tectoral membrane involvement in trauma. So we devised this ratio. When we looked at the ratio between the distance of C1-2 and 2-3, C1-2 is distracted greater than 2.5 times the C2-3 distance, then all these patients had tectoral membrane abnormalities. So here's an example where we have C1-2 distraction, and this is distracted in tectoral membrane injury. Really, we think that it's because whenever there's laxity in the front, and all these children are actually supine when they got these x-rays. So when they're supine and the tectoral membrane is lax, the back of the head puts a little fulcrum or vector anteriorly on top of C1, and when the stabilizing membrane or ligament of the tectoral ligament is loose between the occiput and C2, this allows the C1 to be jacked up. Thereby we see this distraction of C1-2 as a relative comparison to C2-3, indicative of anterior tectoral membrane injury. So this ratio is easily identifiable. We're not looking for the dens, we're not looking for the clivus, and sometimes these really complicated patients with a bunch of lines and intubation. And also we're not measuring a distance. So it eliminates the film distance variable in terms of the millimeters that we had talked about with the other measurements. And it allows us to identify tectoral membrane injury on MRI with 100% specificity, and we propose this as a criteria for OC2 instability in children. So, and moving beyond trauma a bit, we're talking about the other different categories of cranial cervical abnormality. This is a child with spinal epiphyseal dysplasia, whereby we can see that there is instability across the cranial cervical junction, tectoral membrane is lifted up, and this child has a paucity of bone, as you can see. It's all cartilage in the front, and this required fusion. And these children are highly unstable, and they also have posterior compressive injury, so I always try to do these cases in a halo. So in terms of the skeletal dysplasia, there was a Morquio's patient. They have OC2 instability, ligamentous laxity, hypoplastic C-den, foramen magnum, as well as C1 stenosis. So, and they're of very short stature. And the scariest part of the operation for me is actually the flip. So we always do pre-flip motor evoked baselines, flip them in a halo so they're completely stable, and do the operation in the halo. And we do put the halo back on as a postoperative adjunct, but they get it mostly because of the flip and not because of the additional rigidity that's necessarily required after we instrument them. So in terms of additional cranial cervical pathology, one of the most challenging one is due to osteogenesis imperfecta, whereby we have softening of the cranial cervical bones and the brain basically settles on top of C2. And this can be measured by a line from posterior clinoid to the inion. If it's less than 3 centimeters, it's felt that we have basilar impression. So one of the largest series in the literature is by Dr. Menenzies. A lot of these are reducible with traction. If they're not reducible, then the pathology is addressed concurrently with an anterior decompression. These children don't have a problem with fusion, but their fused bone is also very soft. And unless you get rid of the anterior pathology, even with the fusion, they tend to gradually settle. And the goal of treatment, family has to know oftentimes is palliative. And because over time, the anterior pathology that gets worse and worse. And so I've always tried to do a transoral decompression on these. Otherwise, it can become a problem years down the line. So we can also have assimilation disorders whereby the atlas is assimilated to the occiput, and this also causes an anterior pathology where the clivus has a segmental abnormality, which causes it to project the tip of C2 upwards, another source of basilar impression if the clivus is settling down along the anterior part of C1 with assimilation of C1 into the clivus. So this is a case of anterior atlas assimilation, and we have the associated compression of the brainstem, and we know this is a severe compression of the brainstem anteriorly because we also have a syrinx. Although this is not the most dramatic compression that we can see, as illustrated by our other case previously, we know that there is significant compression here because of the syrinx. The CSF dynamics is altered here. So this is whereby the anterior pathology is reduced by posterior open reduction and fixation. And the syrinx, of course, resolves with a more normal anterior subarachnoid space and reduction of the basilar impression. So while we can have anterior segmental issues, we can also have posterior segmental issues whereby the C1 is assimilated into the occiput back here, and this can put an abnormal stress or abnormal development of this transverse ligament. And when you see this patient inflection, we can see that there's atlantoaxial instability here. And this patient is treated with this construct. So in terms of surgical technique, I think you know, a transarticular screw is always nice and confers the best stability in terms of the C1-2 fixation. Oftentimes we do have anatomy that is quite unsuitable for either a pars screw or a transarticular screw in the occipital, the C2 construct. So Dr. Wright came up with this technique whereby translaminar screws are employed. C2 obviously is the biggest spinous process in the cervical spine. This includes children, and they often have enough space to incorporate translaminar screws. So this is our attempt at a translaminar screw in a very young child. You can see that there's significant crowding at the spinous process, such that one of the screws is directed more ventrally, and this patient could have a tiny little breach here. But the other screw is able to reach the length of the lamina. And this is the patient whereby the anterior pathology is again able to be reduced with translaminar screws in a occipital cervical construct. So moving on to just beyond just talking about bony compression, we can often have Chiari malformations whereby the entire posterior fossa is really involved in terms of there is the Chiari, which is the tonsillar descent into the cervical spine. We know that the tonsils should end at the cervical spine or 4 millimeters above or below the foramen magnum. But oftentimes we just have a Chiari malformation that we deal with surgically, but oftentimes the Chiari malformation comes with the basilar invagination and the platybasia, and you can't just decompress this posteriorly with a pure decompressive operation. This anterior pathology has to be addressed. So this is a case where the patient preoperatively, you can see that there is existing anterior pathology. There's a significant Chiari malformation. Chiari is decompressed, and the basilar impression is much worse with cranial nerve dysfunction. So we would like to able to predict this before we do a posterior decompression, so that we do have some measurements. If the dens is sticking back more than 9 millimeters along the clival to C2 line, we have to worry that this patient will need a concurrent fusion to prevent worsening of the anterior pathology. Or if the clival angle is greater than 130 degrees in terms of this flatness, this is another potential indicator that we'll need to address the anterior pathology concurrently, either with a posterior fusion and open reduction of this. So here's an example. This is an 11-year-old child with Chiari. We have the anterior pathology. Patient also had presented with downward nystagmus and ataxia. There's also some clipophile fusion here. But we were able to do a C3 lateral mass screws with an occiput to C3 construct because of the fusion here with a wire underneath C2 around the spinous process of C2, and you can see with this construct, we're able to get a nice post decompression or reduction of the anterior pathology and a subsequent fusion. So just want to point out again that bony relationships and ligamentous integrity can be subtly manifested by a syrinx. What do we mean? This is a patient with anterior pathology and basilar impression. Between these two scans, you can see we've developed a significant syrinx. Well, this means that this either the posterior Chiari or the anterior relationships has worsened so that CSF is now completely blocked from the cranial-cervical junction, and we can develop a syrinx. So when we look at progression of cranial-cervical abnormalities or instability, we want to look at the neural elements, and we want to not forget to scan the rest of the spine to look for a syrinx, which could indicate progression of the cranial-cervical pathology. So, to summarize with basilar impression and Chiari, selective basilar invagination anterior pathology with Chiari 1 and/or syrinx presents cranial-cervical instability, and they should be treated with posterior open reduction and fusion. With the really scary anterior pathology, I think we still would advocate a transoral odontoidectomy for me, sometimes it's just the brainstem is just a ribbon, and just doing a posterior reduction may not be enough, or if something happens during surgery, you just have no room, no margin of error. Talking a little bit about Down syndrome, which of course can have instability at the cranial-cervical junction or between C1-2. We can have a lax transverse ligament. We can have AO motion greater than 10 millimeters. And we can have cord signal change from dense abnormalities or osodontoideum. I think this is a very challenging group of patients when they need cranial cervical fusion or C1-2 fusion, because we do know that they have a noted difficulty with graft reabsorption and lack of fusion, and problems with non-union. This is an example of a patient, and they can present quite young. So this patient is 4 months of age, and we have cranial cervical dislocation at this point already, and a fusion was attempted posteriorly without instrumentation, just halo with a C1 laminectomy, and this has resulted in non-union. And then at 13 months, I met this patient, and we did a rib graft, we did microplates, and we did many craniofacial plates and screws to sew it in place. But you can see over time, this graft still reabsorb. And consequently, we used bone morphogenic protein on this patient. This is the first reported case use of bone morphogenic protein in a pediatric patient that we reported. And it's just, there was just no other way to really achieve a fusion on this patient. And so with the use of bone morphogenic protein, we got a massive fusion. And so I was looking at this and I was like, wow, it held this way. It didn't grow through the skin. So we can also have unstable osodontoideum without Down syndrome, of course, where this patient has an unstable os. So I'm showing this picture just to remind people that when we have scoliosis, it's not necessarily just a spine problem. We're mindful that hydrocephalus here can cause a Chiari, can cause a syrinx, and cause a scoliosis. And this patient was treated with endoscopic third ventriculostomy, whereby we diverted CSF through the base of the third ventricle, and then the Chiari resolved and the syrinx also resolved. Just talking a little bit more about Chiaris, I think it's very We have to be mindful when we're really sophisticated when we think about the syrinxes and scoliosis, which this patient has a little bit, that this patient actually has a syrinx, but we could not find a Chiari here. The tonsil did not descend into the cervical spine. And then we're like, you know, with this image, it's just really hard to see with the BFFE Fiesta type of myelogram image. We just can't tell what's happening here. And why does this patient have scoliosis? Why does this patient have a Chiari that won't go away? And we finally were able to do a cardiac gated image, and I'm just going to show us this real quick, that can show us that this in fact is a membrane that we cannot see on traditional images, but if we gated it with cardiac imaging, we can see that this is a membrane that would just act just like a Chiari to disrupt the cranial cervical junction CSF dynamic, which causes this patient's syrinx. So this is a very cool way to image CSF dynamics and the processes that kind of goes on in the cranial cervical junction, of course, beyond bony relationships. And this is the membrane that we can see intraoperatively above the spinal cord. All right, so in conclusion, there's a lot of cranial cervical abnormalities. In terms of the stability, we need to think of it as one unit. We need to think of its relationship to neurological structures, and we're not able to be really sophisticated and really be encompassing and holistic if we just look at the bony relationships or just look at the intraspinal / intracranial relationships. And we also have to think about CSF dynamics. So thank you very much. Thank you for your attention, and have a great day. Stay safe. Enjoy the other talks. Bye-bye.